Good afternoon, good evening, good morning to all of our attendees into this Congress. Welcome everywhere. Thank you very much for attending this very important session in pediatric endocrinology. This session, we are going to meet a couple of international experts in pediatric endocrinology, Professor Jan Martin Witt from Netherlands and Professor Zulf Mughal from United Kingdom. Our first speaker is Professor Jan Martin Witt. Professor Jan is Emeritus Professor of Pediatric from William Alexander Children's Hospital, Leiden University Medical Center in Leiden, Netherlands. Professor Jan Martin Witt studied medicine at Leiden University and specialized in pediatrics and pediatric endocrinology at Sophia Children's Hospital in Rotterdam. After a 3-year position as a general pediatrician in Dominica, he was associate professor in pediatric endocrinology in Utrecht for 13 years. Then he became professor of pediatrics and vice chair of the Department of Pediatrics at Leiden University Medical Center for another 13 years. Since 2006, he became an emeritus professor. The main focus of his scientific work is the regulation of growth and diagnosis and management of growth disorders. In 1986, he founded the Bureau of the Dutch Growth Research Foundation and the Dutch Growth Hormone Advisory Group, which has actively studied novel indications for growth hormone therapy, including in idiopathic short stature. Under his supervision, 47 PhD students defended their thesis, and he authored more than 700 scientific papers and chapters. He received several awards, including the Andrea Prada Prize from the European Society of Pediatric Endocrinology, ESPE, Gorta Medal from the Dutch Pediatric Association, and Visionary Award from the Human Growth Foundation. In the last decade, he has mainly worked on genetic causes of short and tall stature. So, Professor Jan Martin Witt, the floor is yours.
Good afternoon, ladies and gentlemen. It's my pleasure to speak with you about short stature and particularly to show clinical case scenarios. Here are my disclosures, advisory boards, and speakers' fees, usually on the diagnosis of short stature. So the first case is a short 8-year-old boy. And again, we like to use a stepwise approach in the diagnostic procedure. In the first place, what are the frequent or relevant causes of primary and secondary growth disorders? And then we have to know the relevant questions and issues in the medical history, physical exam, and analyzing the growth curve. The third issue is to perform screening, which is laboratory and radiology. And fourth, collect the diagnostic clues for a primary or secondary growth disorder, assess their probability, and perform further testing. So what are these primary and secondary growth disorders that we are talking about? I think a very nice classification of disorders is whether a growth disorder comes from the epiphyseal plate or from outside of the plate. And you can see here the primary disorders are located in the epiphyseal plate, and they can be defects of intracellular mechanisms, paracrine signals, or abnormalities of extracellular matrix. So it's all about the chondrocyte. The secondary disorders come from endocrine signals, so all from outside of the growth plate, nutrition, extracellular fluid, for example, tubular acidosis, inflammatory cytokines, for example, in arthritis, etc. And of course, if we don't know, we call it idiopathic. So there are three main classes of disorders. Now, in more detail, the primary growth disorders are particularly clinically defined syndromes, and there are hundreds of syndromes associated with short stature. And these can be caused by chromosomal defects, copy number variants, or genetic or epigenetic defects. And then there's a separate class, one can say, of skeletal dysplasias. And of course, FGFR3 is the major one that is known. But there's now a new class of apparently isolated short stature, which is caused by genetic or epigenetic defects. So they look normal, so they're not really syndromic. And the best examples that we know now are the heterozygous variants in genes associated with skeletal dysplasias, such as SHOX, NPPC, NPR2, ACAN, Indian hedgehog. The secondary disorders can be endocrine, gastrointestinal, other organ systems, psychosocial, and iatrogenic. And that has not changed very much over time. And then there's idiopathic, so one can call it is isolated short stature. If children are born, one can call this idiopathic STA. And if they're born appropriate for gestational age, you usually call it idiopathic short stature, so ISS. So here are the three main groups of disorders that we're looking for. And of course, the idiopathic is actually if you have not found any primary or secondary disorder. Then the second step is, of course, what are the relative questions and issues? And here there's a summary or selected clues for a primary disorder. The clues for the secondary disorders are not shown because of time constraint. And you can see them in the paper that we published 2 years ago. So in red, there are some things that I would like to highlight. SDA per se is already a good reason to think of a primary disorder. And feeding problems is an important thing to ask because there are several disorders, Silver-Russell, of course, but also IGF-1R, haploinsufficiency, Noonan and Prader-Willi, that have feeding problems in infancy very frequently. A new question to ask in the family history is there any early onset osteoarthritis or discopathy in the family, particularly in the short members of the family? And then in the physical exam, it's already a long time known that asymmetry is an indication of Silver-Russell, but it's now very important to look for disproportion in great detail, also to see if it's more the upper arm that is short or the forearm that is short. And of course, similarly in the legs. Head circumference, very important always to measure because microcephaly and relative macrocephaly are indications of several disorders. And muscular hypertrophy is a new sort of sign at physical exam that is associated with shocks. And then it's very important not only to calculate mid-parental height, target height, but also look at the height of the parents separately. Because if the child has a similar height SDS as one of the parents, a dominant abnormality is of course likely. So what about our first case? He had a normal medical history, normal birth weight, length, no feeding problems, normal development. The family history is interesting because the father is tall, about +1 SD for the Dutch standards, but the mother is very short with a stocky build. And there's a younger sister of the boy who has a similar growth curve, but a little bit less low than he. At physical exam, there's no dysmorphic features, normal head circumference, but he has rather short legs. Sitting height-height ratio is 2 SDS. And the arm span minus height is 3 centimeters, so he has rather long arms. Now, if you look at the growth curve, there is a deceleration from 0.5 to 3 years, but after that, there's a height that is stable at -3 SDS, as you can see at the right side of the slide. So I was talking about body proportions. I just show one slide on the most important ones. That is sitting height-height ratio, and you can see the enormous effect of age on this ratio. And we just published last year reference data for relative arm span divided by height here, and arm span minus height. And you can see there's also some age dependency there. And these body proportion markers can be used to make a decision whether one should do some genetic testing. And here I show the example for shocks. We published actually that in the Dutch patients, if there is a short stature and either the sitting height SDS is over 1, or the arm span is more than 3 centimeters below height, then you have a rather high likelihood of finding a shocks haploinsufficiency. Of course, also test for shocks if there are typical signs of Léry-Weill, and also if you see some findings of Léry-Weill in one of the parents. So there are 3 sort of indications to do this shocks investigations. And then we come at number 3, the screening. This is, of course, the first part is actually the regular textbook, the total things, but we added actually 3 things. We added here that the radiologist and pediatric endocrinologist not only should check bone age, but also check for anatomical features, because these novel disorders that we found over the last 2 decades actually often had anatomical abnormalities on the X-ray of the hand. Then in the younger children, we add blood gas and BP3, as you can see. In the children over 10 years and a decreasing or a low BMI, we add inflammation markers and feces calprotectin to check for inflammatory bowel disease. And for girls who are short or short for the target height, we still advise to check for Turner syndrome, but we give into consideration to use a karyotype or an array analysis. I come back. So this is the flowchart that we proposed in our guideline in the Netherlands. All children who are referred for short stature and or gross faltering to the general pediatrician, so this is for general pediatricians, collect medical history, family history, physical exam, and the gross data, do the screening, and then you can already find diagnoses like Turner syndrome. And if you use the array, also copy number variants and uniparental isodisomy, you already find hypothyroidism and celiac disease. And if there is at least one clue for primary growth disorder, if the lab is normal, and usually also bone age is normal, one can consider genetic testing. If there's at least one clue for a secondary disorder or an abnormal lab, for example, a low IGF-1 or so, or a severe bone age delay, one could do specific testing to check for those possible causes. And if there's no clue for a primary or secondary disorder and the lab is normal, one can usually stop investigations unless height is very, very short. So back to the patients. This is a patient with low normal birth size, suspect of dominant inheritance because his mother was also short and his sister, disproportionate, and the relative arm span in the upper normal range. A typical growth pattern that is seen in the primary disorders, an early deceleration followed by a stable curve at about -3, also seen actually in syndrome of Turner, and no bone age delay. What did we do? There was insufficient specific features to look for one gene defect. So we did a next generation sequencing based growth gene panel. And what we found was a novel heterozygous missense ACAN variant, which was pathogenic in silico. We did segregation analysis. The variant was present in the affected mother and sister, not in the unaffected father. So the diagnosis here is a familial short stature due to ACAN haploinsufficiency. And ACAN is the gene that encodes aggrecan, which is a cartilage matrix protein. We then asked, actually, in the extended family about discopathy and early osteoarthritis. And indeed, the mother and her short father suffer from discopathy and osteoarthritis. So what are the observations in patients with ACAN haploinsufficiency? There's a very nice paper in 2017 on 103 patients, and you can see that height decreases by age, just they lose by age. The relative arm span is normal in children and seems to be elevated in adults. And you can see that that the sitting height ratio is relatively high. So they have rather short legs, but there's a large overlap, as you can see, with the normal range. Now, I told you that we had made new reference data for the arm span. And when we adjusted for age and sex, so used the relative arm span SDS, we saw that the relative arm span is actually rather normal in most children, with 2 exceptions, but is elevated usually in adolescents and normal actually in adults because there is an age dependency. In this study, the bone age advance was actually 0 to 3.7 years, so clearly advanced. That's probably due to selection, because later studies showed that about 50% have a normal or even delayed bone age. So the advanced bone age is not seen in all patients. So consider an ACAN haploinsufficiency if there's an early growth deceleration followed by stable low height SDS, if there's short stature and or early occurrence of relapsing knee or back complaints in one side of the family, if there's a stocky disproportionate build with a mild mid-phase hypoplasia, if there's a normal to increased arm span in contrast to sitting height in the upper normal range or above, if there's brachydactyly or advanced bone age without signs of hormonal overproduction. And you can see that these children can look rather normal. Then a second patient, a 4-year-old boy with severe short stature. He had borderline SDA. The father had a normal height, but again, the mother was very short, minus 3.5 SDS, and again, a stocky build. And the younger brother of 2 years also grew poorly. At physical exam, there were no facial dysmorphisms, no microcephaly, an increased sitting height ratio, a normal relative arm span, minus 3 centimeters. And again, a progressive deceleration in the first year, and then a stable low SDS. Again, we thought that here, most likely an autosomal dominant short stature would be possibly heterozygosity for one of the skeletal dysplasia genes. And again, we did this NGS gene panel and found, in this case, a heterozygous pathogenic missense variant in NPR2, again, segregating with the affected mother and brother. So the diagnosis here is NPR2 haploinsufficiency. And what is that? There are children with a rather normal phenotype, although they tend to have some frontal bossing, as you can see here. It's dominant, of course. They can have short metacarpals, they can have short distal thumb phalanx. In general, their phenotype is similar to the SHOX haploinsufficiency. Some of these cases have been responding to growth hormone rather well, others not that well, as you can see. So you can ask, what is now the diagnostic yield of genetic testing in these short children? There's one very nice study from Germany that actually has investigated this. They started with 565 individuals with unexplained short stature or growth reduction. Some had mild learning disorders, some had microcephaly, so that was not an exclusion criteria. The first step that they did is they asked a clinical geneticist to do a systematic phenotyping of the growth pattern, dysmorphic features, radiology, psychomotor development, pedigree, etc. And there was a diagnostic workup of common and recognizable causes, a targeted genetic testing. So if you would send your patient to an experienced clinical geneticist or pediatric endocrinologist. And the diagnostic yield was already 13.6%. And half of those were the copy number variants, the CNVs. Step 2 was that in 200 of these children, a gene panel was done, 1,000 genes, so no hypothesis, so without any hypothesis. And there is an additional diagnostic yield of 16.5%, so pathogenic variants in known short stature genes. So the combined diagnostic yield is 33%, often with important clinical consequences. So the yield of the very short child, usually one makes a sort of limit of -3 SDS, is actually rather high. So in conclusion, collect diagnostic clues from the medical history, physical exam, and growth pattern to assess the likelihood of a primary or a secondary disorder. Perform then standardized laboratory screening. Check the X-ray of the hand and wrist, not only for bone age, but also for anatomical anomalies. Test for Turner syndrome if height SDS is lower than -2, or if it is lower than the target range. And you can use a karyotype if it is clinically suspected for Turner syndrome, or we can choose an array analysis where Turner syndrome is picked up, but also other copy number variants. You can also check the available clinical scores and criteria for Noonan, for example, Silver-Russell syndrome. I mentioned the SHOX score, and we also prepared an IGF-1R score that I had no time to discuss in detail. Consider a genome-based targeted gene panel if a primary growth disorder is suspected. And the cumulative frequency of genetic causes is about 15 or 13%, depending on the patients that you include. This is the end of this talk, ladies and gentlemen, but I'm sure that much more genetics and epigenetics is around the corner. For more details, see our paper on the guideline that we prepared for the Netherlands in Hormone Research Pediatrics, and the review on STA-born patients in endocrine reviews. Thank you very much.
So thank you very much, Professor Jan Martin, for this fascinating talk. I should remind our colleagues to prepare their questions and write them in the Q&A session. We'll take you through the next 25 minutes with an international expert who had contributed heavily and supported lots of colleagues from the Gulf area, Professor Zulf Mughal from the United Kingdom. Professor Zulf is a consultant in pediatric bone diseases at Royal Manchester Children's Hospital. Professor Zulf Mughal graduated in medicine from the University of Liverpool in the United Kingdom in 1978. He received postgraduate training in pediatrics at hospitals in Manchester, Liverpool in the UK, and in Cincinnati at the USA. He was appointed a consultant pediatrician in 1988. He is currently employed as a consultant in pediatric bone diseases at the Royal Manchester Children's Hospital. He has extensive experience in management of childhood bone and mineral disorders. He has more than 30-year experience of managing pediatric cases of generalized arterial calcification of infancy and autosomal recessive hypophosphatemic rickets type 2. Professor Mughal has published more than 180 peer-reviewed scientific papers, invited reviews, and book chapters. Professor Mughal was awarded the Charles Slimenda Award at the 7th International Conference on Children's Bone Health in Salzburg, Austria in June 2015, in recognition for his contribution to pediatric bone research. In June 2021, Professor Mughal was awarded the Dent Award by the Bone Research Society. So Prof. Mughal, the floor is yours to enlighten us about the fragility fracture and osteoporosis in young people.
Good evening, everyone. I would like to thank the organizers for inviting me to speak at this important meeting. I have no disclosures in respect with this talk. So the learning objectives of this talk are to talk about fractures in children, causes of osteoporosis in children and adolescents, and how do we assess a child with fragility fractures. And finally, I'm going to discuss primary and secondary osteoporosis in children with the help of 2 case studies. So first of all, it's important to say that fractures in children are common. This is a study from United Kingdom General Practice Research Database, which looked at incidence of fractures in children in boys and girls. By the age of 17 years, 30% of children will have sustained at least 1 fracture. And the peak incidence of fracture coincides with the peak growth velocity in girls and boys. Because boys have slightly longer period of pubertal period compared with girls, they get sort of degree of intracortical porosity, which probably contributes to higher incidence of fractures in boys than girls. What we are not going to talk about are fractures which occur in immobile children where child abuse has to be considered. So a fracture occurs when the load applied to it exceeds its ultimate strength. On the left, we have a radiograph of a child who sustained a fracture of the distal radius whilst playing football. So this is excessive load in a healthy bone resulting in a fracture. In contrast, the 2 radiographs that you can see in the middle panel and the right panel are fragility fractures. This one, in a boy with osteogenesis imperfecta, you can see compression fractures of 3 vertebral bodies, which occurred simply through sitting or standing. There was no significant trauma. And on the right is a radiograph of a child with cerebral palsy who never walked, and therefore his or her bones have become very gracile. You can see very thin femur. So the bending or the torsional force required to break this slender gracile bone is much less than that of a healthy bone. So these are examples of fragility fractures. In an adult, you can diagnose osteoporosis based on bone density measured by DEXA or dual energy absorptiometry shown here. So if the standard deviation score or Z score for the peak bone mass is minus 2.5 or greater, known as T-score, then you can diagnose osteoporosis and consider all the appropriate supportive and therapeutic measures in this individual. In contrast, in children and adolescents, the diagnosis of osteoporosis cannot be made on the basis of bone mineral density alone. So to make the diagnosis of osteoporosis in children, you need 1 or more compression fractures of vertebral bodies in the absence of local disease or high energy trauma, or the presence of both a clinically significant fracture history and size-adjusted low bone mineral density. So what is significant fracture history? That is 2 or more long bone fractures by the age of 10 years, or 3 or more long bone fractures by the age of 19 years. And this is from the pediatric section of the International Society of Clinical Densitometry, which reviews all the available literature as well as input from experts internationally. So you can divide the causes of osteoporosis in children into primary bone disorders and secondary bone disorders. Primary bone disorders include inherited disorders of connective tissue such as osteogenesis imperfecta, Ehlers-Danlos syndrome, and idiopathic juvenile osteoporosis. Secondary bone disorders include long-term treatment with glucocorticoids, chronic inflammatory disorders such as juvenile chronic arthritis, other chronic childhood illnesses, particularly if they're associated with malabsorption, such as cystic fibrosis and chronic liver disorders. Childhood cancers, whereas particularly they are treated with chemotherapy, glucocorticoids, and anti-rejection medications. And neuromuscular disorders associated with immobilization, in particular cerebral palsy and Duchenne muscular dystrophy in boys. Primary and secondary hypogonadism in conditions such as anorexia nervosa, poorly treated thalassemia major, and galactosemia. So we'll be focusing on osteogenesis imperfecta and inflammatory bowel disease later on in this talk. So the assessment of the child starts with a carefully taken medical history, focusing on a detailed account of how the fractures occurred. Does this child have a chronic backache? And the musculoskeletal examinations, you will all be familiar with the PGAL system. You can Google this or go onto YouTube and you can find very nice videos on how to do the PGALS assessment. Pubertal assessment is important. As in my rickets talk yesterday, I mentioned assessment of dietary calcium intake, which can be done quite easily in clinic. You need to measure serum levels of calcium, phosphate, alkaline phosphatase, parathyroid hormone, and 25-hydroxyvitamin D. Obtaining a spinal radiograph or vertebral fracture assessment by DEXA is important, and I'll talk a little bit about VFA, and bone mineral density measurement by DEXA. In few cases, we do transiliac bone biopsy with tetracycline labeling. So DEXA has major challenges in children because it measures areal bone density. In other words, dividing the bone mineral content of bone by its area. And I can illustrate this by showing these two cubes here, which are made of the same material and therefore have the same volumetric density of 2 grams per centimeter square. But if you divide this mass by this area in a smaller cube, you end up with areal density of 4 grams per centimeter square. And the larger cube, areal bone density of 6 grams per centimeter square. Now you can replace these cubes by a 7-year-old short child, but healthy, with another 7-year-old bigger child who are both healthy. And they will have totally different areal bone mineral density values. And therefore, we need to make appropriate adjustments to this in order to derive what's known as bone mineral apparent density by, for example, in the lumbar spine, modeling it as a cube, and at the femoral neck as modeling it as a cylinder. And we have published normative data in United Kingdom for 800 healthy children and derived centile charts for this bone mineral apparent densities as shown here. And you can see that in contrast to areal density, which goes up, the volumetric bone density or bone mineral apparent density is fairly sort of uniform and therefore not affected by size as much as areal bone density. I don't have time to discuss all the aspects of DEXA, which is a talk in itself. So spinal radiographs or assessment of the spine is important. Here you can see conventional radiograph of the thoracic spine and lumbar spine. And in the same child, my colleague, Dr. Nick Crabtree, performed vertebral fracture assessment by DEXA. You can see that the visualization of the thoracic compression vertebral fractures is far superior in the DEXA VFA as opposed to conventional radiograph. Moreover, the radiation dose for DEXA VFA is considerably smaller than that of DEXA VFA. And it's available at the point of care. In other words, when you do a DEXA scan to measure bone mineral density, you can request DEXA VFA at the same time. So the approach to treatment of a child with primary or secondary osteoporosis who fulfills the criteria for osteoporosis, as mentioned previously, one or more compression fracture of vertebral body or a significant fracture history with low size adjusted bone mineral density, is to treat the underlying disease where it is possible. So if you have somebody with for example, inflammatory bowel disease or another inflammatory disorder, just controlling the inflammation will result in improvement in bone mass. And even if they have compression fractures of vertebral bodies, as long as they are growing, then there is a good chance that those fractures will reshape. So treating underlying disease is very important. Optimizing their dietary calcium intake, making sure that they have adequate stores of vitamin D. When they feel well enough, it's important to use their muscles by weight-bearing activities which are trophic to bones. Assess and treat delayed puberty, which I'll come on to later. If they are symptomatic and if their fractures are not likely to remodel in a chronic disorder like primary osteoporosis, then you may consider judicious use of IV bisphosphonates. And of course, then you reassess them both clinically and by imaging and biochemistry every year and adjust your treatment plan. So that is the approach. So now let's turn to one of the primary bone disorders, that is osteogenesis imperfecta. So osteogenesis imperfecta is an inherited disorder of connective tissue associated with increased propensity to fracture and skeletal deformity. It's also associated with hypermobility, short stature, scoliosis, basilar invagination, rather fragile skin, increased hernias, blue sclera, muscle weakness, which is very important, and some of them have this dentinogenesis imperfecta and early hearing loss. The classification or the nosology is very complex. In 1979, David Salentz divided it into 4 different types of osteogenesis imperfecta, type 1 being the mildest or the non-deforming form, type 2 being the severe perinatal form, usually lethal, and type 3, the progressive deforming form, and type 4, intermediate in between type 1 and type 3, who may have normal teeth or dentinogenesis imperfecta. And then we had type 5 described and type 6. And in the last 20 years, there's been an explosion of genes which we now know are involved in collagen synthesis or skeletal mineralization, which cause both dominant and recessive and X-linked forms of osteogenesis imperfecta. And this really just shows the overview of collagen biosynthesis. So after translation, you get pro alpha 1 and alpha 2 chains of collagen, which then undergo post-translation modification carried out by proteins which are encoded by all these particular genes. And then there is collagen trafficking and folding to form this triple helix. And then there is further modification which goes on in the Golgi apparatus. And then it's extruded out of these cells where you then get cleavage of the propeptides at the C and N-terminal things. And the early collagen fibers are then cross-linked to form fibers of collagen. All these processes are encoded by genes, and any mutations in any of these genes can give rise to osteogenesis imperfecta. And there is a dominant form of osteogenesis imperfecta, which is involved with skeletal mineralization. And there are 2 genes which cause X-linked type of osteogenesis imperfecta. So quite a complex things, but 90% of osteogenesis imperfecta, at least in the UK, are caused by mutations in COL1A1 and COL1A2 genes. So we'll be talking later on about osteogenesis imperfecta type 8 caused by LEPR gene. So this just shows the blue sclera, the dentinogenesis imperfecta. Skull radiograph will often show vermian bones. The radiographs often are slender, osteopenic, and in type 5, you may see this sclerosis of the metaphyses in the neonatal or early infancy. So there is no cure for osteogenesis imperfecta. The mainstay of treatment is really prevention of fractures and enabling these children and adults to live as normal a life as possible. So this involves a multidisciplinary approach to give them advice about handling and day-to-day care. Physiotherapists play an important role in strengthening their muscle, improving their posture, dealing with hypermobility and gait issues. Occupational therapists may be involved in providing a wheelchair for more severe forms of, for children with more severe forms of osteogenesis imperfecta. And when they're in school, their hands may become very tired due to sort of hypermobility, and they need special writing and drawing aids, or may need access to a tablet or a computer to enable them to write. But dietary and orthotic input is very important, and all health professions have to liaise with the school to make sure that these children are able to access the educational curriculum to the full as an able-bodied child. So turning to the medical management, in those children who have recurrent long bone fractures or compression fractures of vertebral bodies, we consider treatment with IV bisphosphonates, which I'll come on to shortly. Vitamin D supplements are important. Dental care is important. Periodic screening for hearing loss is important. And of course, our best friends are orthopedic surgeons and spinal surgeons who help us to manage fractures and scoliosis. If they have base of the skull problems involved with Kihari malformation or syrinx, then neurosurgeons play an important role. So bisphosphonates are analogs of inorganic pyrophosphate, and in treatment of children with osteogenesis and Imperfecta, we use nitrogen-based bisphosphonates, mainly pamidronate and zoledronic acid, and these are by osteoclasts and cause premature apoptosis of these osteoclasts. So here you have cortical bone, and on the periosteal side, you can see osteoblasts causing bone formation, and the endosteal sides, the osteoclasts chewing up the bone and removing the bone. But if you can sort of cause apoptosis of this osteoclast, you can stop or reduce the bone resorption, and this will cause thickening of the bone. So the bone quality is not completely normal, but having thicker and more bone translates into fewer fractures. So bisphosphonates result in improvement in bone density, reduced fracture incidence, reshaping of vertebral fractures in growing children, reduction in pain, and improvement in mobility. The symptoms are acute phase symptoms with first infusions of fever, bone pain, headaches, nausea, which are less likely to occur with subsequent infusions. If they are vitamin D deficient, they may be prone to hypocalcemia. Some develop hypophosphatemia, though that's rare. Boys with Duchenne muscular dystrophy are prone to rhabdomyolysis, and you can develop transient iritis or uveitis. This bisphosphonate lines that you often see on radiographs are mineralized cartilage, which can sometimes act as stressorizer, leading to interface fractures. So this is a child with type 8 osteogenesis imperfecta at birth. You can see fractures in utero, multiple compression fractures of vertebral bodies, soft deformed skull, and rib fractures at birth. She was around about the age of, I think, 5 months. She had a Portacat put in and was started on bisphosphonates. You can see that by the time she was 6-year-old, most of these compression fractures of vertebral bodies had remodeled, and her size-corrected bone density was normal. Her limb deformities were corrected by insertion of telescopic fascia duval rods. This video was to show her walking in a frame, but obviously it doesn't work. I'm going to finish off by talking about secondary osteoporosis and talk about a boy who presented at the age of 14 years, or was referred to us by our gastroenterologist because he had persistent backache. He had Crohn's disease, which was diagnosed when he was 12 years old. He was treated with elemental nutrition and mesalazine, but continued to have flare-ups which required treatment with pulses of methylprednisolone and courses of oral prednisolone. And he presented with a 3-month history of persistent backache. The risk factors for development of osteoporosis in children with Crohn's disease are predominantly inflammation, which results in production of cytokines, which reduce bone formation and increase bone breakdown. And any chronic illness will delay puberty, which has a profound effect on bone geometry, particularly in boys. So you can see that the effect of delayed puberty on a bone is to cause them to elongate, and they don't get this periosteal apposition and become bigger. And consequently, the bending and the torsional strength to break the bones of a boy who's has had delayed puberty is really less than that of a child who's gone through puberty at normal time. Malabsorption, ill health leading to reduced physical activity and low muscle mass contribute to osteoporosis, and of course, the use of glucocorticoids, which have multiple adverse effects on bone. His oxology, height was on the 25th centile, weight under the 0.4th centile. He was prepubertal. His serum levels of calcium, phosphate, alkaline phosphorus, and PTH were all normal, and 20-hydroxyvitamin D was less than 50 nanomoles per liter. We ideally like to keep levels up to 75 in children with chronic illnesses. And his size corrected lumbar spine bone mineral apparent density was low, as was his femoral neck bone mineral density Z-score. And when we did radiographs, it showed multiple compression fractures of his thoracic and lumbar vertebral bodies, as shown by red arrows here. So his management control consisted of controlling his underlying inflammation, by far the most important way of improving his bone health. And he was started on biologics, biologic treatment by our gastroenterology colleagues, attention to nutrition and correction of his vitamin D deficiency, induction of puberty, and because he had symptomatic compression fractures of vertebral bodies, he was started on IV bisphosphonates in form of zoledronic acid given every 6 monthly. And of course, he was reassessed and every 12 monthly. I'm going to finish off by telling you about emerging treatments of osteogenesis imperfecta and secondary osteoporosis. The first one is denosumab, which binds to RANG ligands and prevents osteoclastic bone resorption. This is already widely used by our adult colleagues, and there are trials of this in children with a variety of different primary and secondary osteoporosis. The second one is trisumab, which targets sclerostin, and binding sclerostin leads to not only bone formation, so this is anabolic, but also reduces bone resorption. And then finally, TGF-beta pathways are upregulated in bones of patients with osteogenesis imperfecta, and monoclonal antibody against TGF-beta has been shown to increase bone formation. So these are emerging therapies, so look out for this, and this hopefully will lead to improved care of our patients with primary and secondary osteoporosis in the future. I'd like to finish off by thanking my the Manchester Multidisciplinary Bone Team, of which I'm a very proud member. We have now a growing group of doctors, therapists, nurses, and two outstanding surgical colleagues here who deal with our problems. So thank you very much for listening.
Very impressive, informative talks that we listened to. Thank you very much for our experts, Prof. Jan Martin and Prof. Zulf Mogal. Now we're going to let our audience ask their questions, asking the experts, and great. Okay, so let's take the first question. The question is directed to Professor Jan Martinwit. What investigations are recommended in a child with hemihypertrophy?
What hypertrophy is it?
They haven't specified what hypertrophy. They just said hemihypertrophy.
Oh, hemihypertrophy. Yeah, that is suggestive for an epigenetic disorder. Of course, you can think of Silver-Russell syndrome, but also other syndromes with some things. And that is very specialized work that should be discussed, I think, with the clinical geneticist, actually, what would be the best gene to test, or maybe even a gene panel, actually, of disorders that are associated with this.
Right. So, so that's okay. So, recommending genetic investigations for that case. A question for Professor Zulf Mogal. What is your opinion in starting zoledronic infusion for osteoporosis with history of fracture in oncology patients still under chemotherapy? Would that increase the risk of the side effects or not?
Thank you very much. So I don't know, I can't seem to switch on my camera. I don't know whether the controllers can switch on my camera, but I hope you can hear me. So it's very well known that many cancers, particularly leukemia, you get, so hopefully you can see me now.
Yes, we do
So
see
in,
you, yes.
in leukemias, just treating leukemic patients, who often have fractures will lead to reshaping of the compression fractures of vertebral bodies. So my approach would be that if they're symptomatic, then please treat them with zoledronic acid or pamidronate. But there's a good chance, particularly in a younger growing child, growth is bone doctor's best friend. So, growth plus controlling the underlying oncological conditions such as leukemia or cancers will lead to reshaping of vertebral bodies. But there is a need for treatment with bisphosphonates. And of course, many of them get avascular necrosis, which is a very painful condition. And we often use bisphosphonates to control their pain. I'm not quite sure that bisphosphonates actually have any role in altering the course of avascular necrosis.
Okay. Thank you very much for that. Another question for you. Do you recommend doing a DEXA scan in osteogenesis imperfecta type 1 in the absence of fracture? If no, how would you follow and treat?
So thank you for that question. So as I mentioned that in osteogenesis type 1, if they have not got recurrent fractures or if they haven't got compression fractures of vertebral bodies, then of course there's no need to treat them with bisphosphonates. The standard of care is that they should have annual spinal radiograph or vertebral fracture assessment by DEXA, because many of these compression fractures occur insidiously and many can be painless. And if you can treat them early, that will allow remodeling. So the answer is that you don't rush in to treat, but you certainly should be looking for insidious onset of compression fractures. I think looking at spinal radiographs or VFA of the spine is more important than bone density.
Okay, thank you very much. A question for Professor Witt. Should we subject all adolescents to growth hormone stimulation tests with height below 3rd centile and height gain of 4 centimeters in age between age of 8 to 12? They said there is no metabolic hormonal profile and X-ray for bone age corresponds with chronological age.
Yes, if I hear these conditions, it looks very unlikely that there is growth hormone deficiency. Of course, there are all these known symptoms and signs of GH deficiency, and the bone age delay is a very important one. And if there's no delay at all, and there's no advanced puberty or so, then it's very unlikely that there is GH deficiency. So I see no need then to test for that. Of course, if he's really short, you could search for other causes, and particularly if you think of a primary disorder, you can have this pathway actually in the direction of a gene panel or something like that, if that is a possibility in your country.
Great, thank you very much. Another question about short stature to you, Professor Witt. A patient who is 8 years old, female, normal karyotype, her height is -4 standard deviation score. She's got delayed bone age of 3 years. Growth hormone stimulation test showed very high growth hormone response to clonidine and arginine stimulation tests in hundreds, suggestive of growth hormone resistance, but normal growth hormone at 0 minute. Normal IGF-1, normal IGF-BP3. What is your approach for this growth hormone resistance?
Yeah, that's an interesting case. It is very likely that this is a genetic cause. Of course, there are a number of TH-resistant syndromes. In the first place, Laurent syndrome, of course, of the receptor, but also STAT5B, and the ALS as well. And there are some rarer forms as well. So in this severely short case, I would certainly do a gene panel actually to check for the known genes. And if that would be negative, you even do a trio DNA sequencing, so whole exome sequencing in the patient and the parents to see if you can find a novel disorder. I'm sure there are still a lot of disorders that we have not yet detected. And of course, these sort of severe cases actually should be really followed up thoroughly.
Great. In limited resources countries, say, for example, Iraq, where they don't have access to genetic testing, would you recommend giving a trial of growth hormone for such a patient?
No, I would not. I would first do the diagnosis, and you can always collaborate with labs in other parts of the world. For example, in our lab in Leiden, we have been studying DNA samples from many countries in South America and Turkey, etc. And if you are really thinking of an important novel sort of cause, a lot of labs will be interested actually to check that. And there are some research facilities in our lab, but also in labs in the United States and in London to do this. So don't stick to your own country in these type of international things. You have to work together with other countries.
Amazing. That's a beautiful message to our colleagues who asked this question. Question to Professor Zulfmugal. Do you recommend using bisphosphonate in bedridden patients who have a very low Z score, -5 SDS, but no fractures? That's the first part of the question.
So in immobile or disabled children, there are many challenges in measuring bone density because many of these patients have scoliosis, and that can give you erroneous results. But as I mentioned, you don't treat bone density. It is important that they have a significant fracture history plus low size adjusted bone density, which is important. So unless this patient has compression fractures of vertebral bodies or has suffered 2 or more fractures by the age of 10 years and has low size adjusted bone mineral density, I would not prophylactically treat with bisphosphonates. Remember that bisphosphonates are not licensed for use in children.
Okay, excellent. When would you change the zoledronic acid dose to annual rather than every 6 months?
That's a very good question. So one of the reasons why we use 6 monthly doses is because of the high turnover that children have. So if, for example, you're treating a patient with osteogenesis imperfecta, their fractures are getting better, their spine has reshaped and their bone density is normal, and they're approaching adulthood. So from the age of 15, 16, then you can sort of switch them to the adult regimen, which, as you say, is annually, or sometimes we just give half the dose, so the normal dose is 0.05 milligrams per kilogram. We may give 0.025 milligrams per kilogram every 6 monthly, or as you say, go on to an annual regimen,
Fantastic. Another question while we're talking about the DEXA scan, do you go by the vertebral score of the standard deviation score of the bone health index, or do you go by the total global score?
Sorry, I missed part of that question. Could you repeat that, please?
Do you go by the vertebral score for the bone health index Z score, or do you go by the global score of the skeletal survey?
So I think probably the question refers to estimating the bone health index from the hand radiograph. Is that right? Because, by looking at the metacarpal thickness and the shape, you can get bone health index. And that is increasingly being used. And my colleague, Dr. Nick Crabtree in Birmingham, is doing a prospective study, and the STOP study consortium that she's doing, where she's looked at 300 patients with different chronic illnesses. And she tells me, it's not published yet, that the bone health index is a good predictor of future risk of fracture, but it is not yet accepted as a way to assess osteoporosis. I think DEXA still remains the gold standard, as it were. But I think in future, we may be able to use the bone health index derived from the hand radiograph.
Great. Thank you very much. We have another question. It's for Professor Jan Martin. Which genetic abnormalities with SGA warrant growth hormone therapy?
Yeah, at the present time, SDA as such is, of course, already an accepted indication. I believe that genetic testing for the children with SDA with short stature is important because there are some conditions that you would not treat them with GH, for example, the Bloom syndrome, and there are other syndromes like that. So it's important to know that the patient does not have that sort of condition. If there are also patients who are SHOX haploinsufficient or NPR2, and of course, SHOX is an accepted indication. About 30% of the SHOX patients are born SDA. So in the normally SDA thought patients, actually some of them have a genetic cause that would warrant a higher dose actually than the standard dose for an SDA child. So those are some of the reasons actually to try to test your SDA patient before you start therapy. Another thing is that some of them are IGF-1R deficient. They have a haploinsufficiency for IGF-1R. And in these patients, you can accept higher IGF-1 concentrations on treatment, actually, because they are partly insensitive. Well, an additional reason, again, actually, to do the testing actually before therapy.
Thank you very much. For patients with the ACAN gene mutation, do you normally start them on higher dose of growth hormone?
In our country, these patients cannot be treated because it's not an accepted indication, and that actually is actually for most, of course, of the other novel conditions. But we have a system where if the height is short enough, we can do a special dose and a special study, I can say, actually to test if this therapy would be beneficial. For NPR2, the results seem to be rather good, so in the same order as SHOX, but it's not yet an accepted indication, of course. But yeah, if you have the possibility to do it, you can do it off-label, right, if you like. Mm-hmm. For the ACAN patients, that has been done as well. The results are not as good as for the NPR2. And of course, for all of these, no adult height data are available. So it's very uncertain what the effect is really at the end.
Right. Professor Zulf, for patients with osteoporosis, you mentioned that to optimize their dietary intake before considering further treatment, say, for example, bisphosphonate, over how long period would you consider optimizing the dietary intake before considering that the patient needs bisphosphonate?
Sorry, thank you. So I think it's important to treat the underlying condition. For example, as I said, in somebody with inflammation, if you just control the inflammation, or in a leukemic patient, if you treat leukemia, that itself will result in improvement in bone mass and reduce fracture in things. Nutrition is, of course, very important. A sick child will not have enough adequate intake of calcium, vitamin D, and that is needs to be done alongside treating the underlying disorder. I would not say that just you can cure osteoporosis through simple nutrition, the exception being possibly anorexia nervosa, where I think we have noticed that once their BMIs improve, then their bone densities and bone quality improves as well.
Okay. So thank you very much for your talks, and thank you very much for answering the questions from our audience. We enjoyed the session with you, Prof. Jan Martin Witt and Professor Zulf Mughal. Thank you very much for this, and hopefully we'll see you again in person soon. Thank you very much, everyone.